So here we are with cardiac pathophysiology 2. What I've done is to simplify this. And so if you look at the PowerPoint from which this is taken, there are a number of slides that have been removed. And there are a number of slides where I've tried to consolidate and simplify. What is on this recording and the slides that are on here are what would be on the exam. Slides that I have eliminated, slides that I have simplified. It's a simplified, eliminated that you're not responsible for that. So if I eliminated a slide, not going to be on the exam. If I simplified the slide, the complicated explanation is not going to crop up on the exam. So here we go. And okay, so we had done cardiomyopathies, cardiac tamponade, and now it's time for problems with valves. And your main valve that you're worried about are the valves on the left side of the heart. So you're worried about the mitral valve, which is between the left atrium and left ventricle, and you're worried about the aortic semilunar valve, and that's between the left ventricle and the aorta. Okay, so you've got two types of valve problems, and they tend to be caused by bacterial infections. It's valvular stenosis, which is a valve that's too narrow, and valvular regurgitation, and the valve is too leaky. So an example is, okay, let me just explain about a heart murmur. When you assess someone and you are listening to the heart, you might hear between the lubs and a dubs a shh sound. And that is an indicator that the person does have a valve problem, and then you do further tests to find out which valve is it, stenosis, regurgitation, etc., etc. And there are valve replacements, and there are some medications. But having said that, that's what you would hear. The murmur means you would hear a shh sound between the, and that's not going to be on the exam. Okay, so if you have a valve disorder and it is not closing, the whole idea of valves is to stop backflow. You want unidirectional flow of blood. If it starts to backflow, the heart is not acting as an efficient pump, and you are going to have ischemia. The blood that's going to come out of the heart, the stroke volume is going to go down, and then the person is not going to have a fully oxygenated body, and that can lead to all kinds of complications. Now, the thing about if a valve allows blood to flow back, then the heart is going to have to work harder. So that's the increased cardiac work. They have to not only pump what's in the chamber, but they're going to have to repump the blood that was regurgitating or not getting into that ventricle. And that's going to cause, an increase in cardiac work. That's going to mean that eventually, just like congestive heart failure, you're going to have some dilation because the chamber that's going to be most adversely affected, and this is a chronic type of disease, unless you get the valve replaced, then over time it gets worse and worse and worse. Hypertrophy, or the thickening of the left ventricular heart muscle mass, is certainly going to give you a stronger contraction, but that also means that you're going to regurgitate more. And over a period of time, that left ventricle, and the dilation is that the left ventricle is going to get overworked, and it's going to do hypertrophy, but it's eventually going to not be able to correct what is wrong, which is a leaky valve. So chamber dilation, myocardial hypertrophy are compensatory mechanisms to increase the pumping capability of the heart. and they are going to both fail. So eventually the heart fails from overwork. Mitral stenosis. So it's a common valve disorder. It's usually a result of bacterial endocarditis, like the complications of rheumatic fever. Let me give you another example. I have a valve problem that is considered benign. I do have a murmur. So whenever I get a root canal, I have to prophylactically take antibiotics before they do the root canal because the mouth is a filthy place. The mouth does have a lot of bacteria in it. And when they do the root canal, there's a part of that procedure where they directly are going to make contact with blood vessels. And those blood vessels will rupture. They're not large, but that means, however, the bacteria in your mouth can directly enter. And the reason for the antibiotics is that, along with phagocytosis, the antibiotics are needed to make awfully sure that every single one of those bacteria from your mouth that enter the blood during the procedure are going to die. Otherwise, what could happen with my murmur is that if that didn't happen and some of the bacteria in my mouth got to the valves, they just love valves. They are able to get a good foothold on a valve. They, especially ones with murmurs, because they have little nooks and crannies, and then that's going to start an inflammatory response. And that is the endocarditis. So it's not just rheumatic fever, which is something that happened, like was very prevalent in the 1940s, but not so much now, anyways, in this neck of the woods. But the whole thing of asymptomatic murmurs, especially in women, have to be taken into consideration whenever they have a procedure done that is going to open them up to having bacteria in their cardiovascular system. Okay, so the healing after the bacterial endocarditis, the orifice, I love this, the opening of the valve, they become fibrous and fused, and they don't totally close. Think about stenosis as stiff, and the stiffness, because of the scarring, is not allowing the valve to totally close, which makes it a lousy valve because then it's very easy when the left ventricle contracts to have a regurgitation or to have a reflux. I'm going to use the word reflux for stenosis for a valve that isn't closing. And this, of course, happens every single solitary time the heart contracts. So you're going to get a decreased flow from the left atrium to the left ventricle during filling because it doesn't open all the way, doesn't close all the way, so it's a double whammy. And of course, the heart's response to this is, oh my God, I can't get enough blood flow. My stroke volume is down. I've got this reflux going on. I'm going to do hypertrophy. And we know where that leads. Over a period of time, it gets too thick, it doesn't fill right, and the person can end up having a cardiomyopathy, heart failure. Now, next, if I can go next, hello. There we go. Versus aortic regurgitation, and that is mainly a semilunar valve defect. Now that's mainly because the next slide is going to show you aortic regurgitation in the mitral valve. So take that with a grain of salt. It is caused by acute or chronic lesions of rheumatic fever, bacterial endocarditis, syphilis, hypertension, or atherosclerosis. Now, the thing with the aortic regurgitation is that the valves become leaky. They come together, but they don't come together tightly. So the scarring that will occur because of the bacterial endocarditis affects a valve that is regurgitating differently than stenosis. Stenosis, the valve is very stiff and it doesn't open all the way, it doesn't close all the way. The flaps of the valves of the aortic regurgitation, they're okay, but they don't shut tightly enough. So you do get backflow of blood. And in this case, since it's a semilunar valve, like the aortic semilunar, then that is going to mean that a certain amount of blood that should be 100% flowing into the aorta, a certain amount of that will regurgitate back to the left ventricle. And of course, the poor heart has to work harder, etc., etc. So the reflux of blood from the aorta to the left ventricle happens during ventricular relaxation because the pressure is with the aorta. So the pressure in the aorta, once it has all the blood and the stroke volume has filled that aorta, the aorta is highly pressurized. And so there's going to be some regurgitation back when that ventricle is relaxed. And that makes it essentially a very poor pump. It's going to put pressure on the left ventricle to work harder to pump the blood lost to regurgitation, which can lead to left ventricular hypertrophy. Now, this is the type of thing that I have. I have mitral valve prolapse. And mitral valve prolapse is obviously the mitral valve, right? And it's something I was born with. And the flaps don't come together tightly so that the chambers that are affected is the blood flow from the left atrium to the left ventricle. And the prolapse is a term that means flapping in Latin. So when you look at that under something like an echocardiogram, you can actually see the billowing, sometimes it's called, or the flapping of the valve that is in quote-unquote prolapse. And it looks, this is a great YouTube, look at it. He gives you way too much information, but just to see that billowing that goes on. And so the valve billows upwards into the left atrium during ventricular systole. So you're going to get some regurgitation of blood into the left atrium. It's a common murmur, mostly asymptomatic. Why asymptomatic? Because the, let's say, the amount of blood that regurgitates back every time it contracts is fairly minor. Could it get worse? Absolutely. That's the reason why I take prophylactic antibiotics before a root canal, because it absolutely can get worse. If that doesn't happen and it's not another episode of bacterial endocarditis, the person can be asymptomatic for the rest of their life. I've never had a problem, except for the fact that I'm very aware of procedures that could introduce bacteria into the bloodstream. And I mean, you tell the dentist this. The dentist might not know this, or the surgeon might not know this, but those are things that if you know that you have a mitral valve prolapse, you have to be proactive. Okay, so having said that, if it remains asymptomatic, it's not a problem. I don't have left ventricular hypertrophy. If I had another episode, absolutely, I might have to have the valve replaced. Okay, heart failure. We've gone through this before. It's just kind of like a summary before we get into heart attacks. So heart failure is when the heart as a pump is not effective and it doesn't meet the metabolic requirements of tissue. Oxygen, they're talking about oxygen. So acute heart failure, right? Your heart attack, your myocardial infarction, and most of the lecture has been on chronic heart failure. So your cardiomyopathies, for example. And that is going to cause ischemic heart disease, meaning that the person's just not getting enough oxygenated blood into that aorta to meet the demands of all of the cells in the body that require oxygen on a continual basis. So the most common cause is ischemic heart disease, which is seen in the cardiomyopathies as well as others, but all of those cardiomyopathies are ischemic heart disease. Okay, so coronary artery disease is in the United States the most common of the ischemic that I have not talked about. But I'm going to tell you right now, coronary artery disease is going to be covered in much more detail when I see you next. Because on Thursday, I will be going into all the different types of artery and venous pathologies. And whether the artery is a coronary artery or a femoral artery or an aortic artery, they all can have things happen like hypertension or arteriosclerosis, which then compromise the blood vessels and can lead to overworking of the heart. If it's a coronary artery that starts to get blocked, then that can lead to a heart attack, etc., etc. So I will go into a lot more detail, which is the reason why I pulled a lot of slides from this section. So coronary artery disease, called CAD, is myocardial ischemia. Myocardial infarctions are progressions of conditions that impair the pumping of the heart, depriving the heart cells of oxygen and nutrients. Coronary artery disease tends to be detected if the person goes to the doctor regularly, pretty early, and then the whole idea is to try to have it not progress to a total occlusion, which would be a myocardial infarction. So that's the reason why we have stents and different types of surgical procedures to reopen those blocked arteries, coronary arteries, so the person will not progress to a heart attack. Okay, so coronary artery disease narrows anything that narrows or occludes the coronary arteries. The most common cause is atherosclerosis, which we will talk about next Thursday. This is a nice YouTube. I always like animations that can kind of let me see three-dimensional things that are going on. And I'm not going to test you on it, but it's a nice thing. Take a look. It's only a couple of minutes. Okay, last but not least, chest pain. Chest pain, I've heard it called angina, and I've heard it called angina. It's kind of like potato, potato, tomato, tomato. And since most of my professors called it angina, I'm going to call it angina. So when people are starting to have CAD and myocardial ischemia, they will have episodes where they have tremendous pain in their chest. And so it's called angina pectoris because it is in the area of the pectoral muscles, and angina comes from the Latin, which means pain. And there's some sort of problem with blood flow through the coronary arteries, or chronic coronary obstruction. There are three types of angina: stable, unstable, Prinzmetal, which is also called variant. Prinzmetal is actually the name of a guy who discovered it. His name was Professor Prinzmetal. And it tends to be more commonly called Prinzmetal than variant angina, but either one works. And on the exam, I would put something like Prinzmetal in parentheses, variant angina. It's nice to have an objective exam where you don't have to learn how to spell these things. Okay, so stable angina, often elderly, and you're going to have people as they grow older because of an increased chance of having arterial or atherosclerosis, and that is going to obstruct a certain amount of blood flow. And as you have the obstruction get larger and larger, greater and greater, the person will have more frequent um, angina attacks. So since they've already have coronary artery disease, if they don't overdo, then no problem, no pain. If they physically overdo, and this can exacerbate and they can have an angina attack. So you have you know, an 80-year-old person who should be taking elevators and they decide to run up 10 flights, that type of thing. They will have an attack. They will have an angina attack because let's just go here. So chest pain brought about by exercise, gradual narrowing and hardening of the vessels, coronary arteries, so they cannot dilate in response to increased demand of physical exercise or emotional stress. So the thing about stable angina is the best thing to do is to have the person sit down and stop moving. And because if they sit down and relax and rest, it'll go away. The other thing is that you can give them nitrates. These are things like nitroglycerin. And people very often have heard of nitroglycerin tablets that you put under your tongue. And what the nitroglycerin does is it will directly interact with the coronary arteries. They have smooth muscle. And so the smooth muscle is under the nitroglycerin is going to relax, it's going to dilate, and that can increase blood flow, and then the angina stops. Unstable angina, the person is having a heart attack. Get them to the ER as quickly as possible. And heart attacks, very often, the person feels chest pain while they're relaxing, while they're standing up, while they're sitting down. They're not running a marathon, they're not running up 10 flights of stairs. But all of a sudden, they have tremendous chest pain, even though they're not doing much of anything. And that is a total blockage. And that person is having a heart attack, and that person needs to be seen as quickly as possible to minimize damage. So, pain is experienced at rest, dangerous, and should be treated immediately since the person is having a heart attack. Now, the heart attack, I am going to go over more on Thursday, but essentially what it means is if a person has a total blockage and they're having the unstable angina and they're having a myocardial infarction, you have about a half an hour to get them to the ER, to get them a clot buster that then is going to reestablish blood flow. If the person presents to the ER before that half hour is over, then a lot of the cardiac tissue can be saved. If it's after 30 minutes, then it's going to die and it cannot be replaced, and scar tissue sets in and you've lost a certain amount of cardiac function. More about that on Thursday. But that's a lot of things that can happen to older people. Things that can happen to people your age is the last category. Prinzmetal angina, spelled wrong, pectoris or variant angina is caused by abnormal vasospasm. Vasospasms can happen under certain conditions, and as much as they say at rest, they're not going into what can happen. What can happen is it can be a panic attack. What can happen is it can be a person suddenly is in an environment where it's 20 below zero and they're not putting anything over their face and they're walking in the cold, bitter, bitter, bitter cold, and that cold air, you don't want that to get down to the chest. And if it does, then that can bring on, so it can be changes in weather. It's usually very cold weather or emotional or things of that nature. But it's not a heart attack. They do not have atherosclerosis. What they have is a spasm that is brought on, let's say, walking around at minus 10 degrees Fahrenheit, with not protecting the air that's coming in, and the fact that when it's cold, you do need a scarf around your mouth, because then otherwise that very, very cold air cannot be warmed quickly enough. And that can have a very adverse effect on coronary arteries. So, so it's caused by abnormal vasospasm of normal cardiac blood vessels, can occur in young adults with no atherosclerosis. But believe me, it feels like a heart attack. So, if it happens to a 20-year-old, I still would bring them to the ER just to confirm that that's what's causing it. And then, if that's the case, then you can use, or you would prescribe nitroglycerin tablets for the same reason. They put it under the tongue. Within seconds, the nitroglycerin can relax and dilate the coronary arteries. And yes, it occurs unpredictably, meaning that everything is fine, you're fine, and then you go out in the cold, you just run from one building to another, and the air doesn't get warmed, and you get that chest pain because of coronary arteries do not like cold, and they will spasm. And it will feel like a heart attack, but a 20-year-old is not having a heart attack because of atherosclerosis, but the chest pain is pretty intense. And the myocardial infarction, which is the last slide. So the only thing I'm going to say about it right now is if blood flow in the coronary arteries is totally blocked by a clot, by atherosclerosis, that then forms a clot, which we will go over on Thursday, then downstream from that occlusion, those heart myocardial cells are not going to get their oxygen. And they absolutely need to manufacture a lot of ATP energy in order to contract. And without oxygen, 20, 30 minutes after the blockage, the heart cells downstream will start to die. And if that happens, then that tissue is replaced with non-functional scar tissue. Scar tissue does not contract. And since the heart muscle cells cannot be replaced by other heart muscle cells, you get non-functional scar tissue. The person is knocked down a certain amount for cardiac function, and those are the consequences. And it really depends. The seriousness of a heart attack is going to depend on what chambers can no longer contract efficiently. The worst heart attack is when the coronary arteries in the left ventricle start to become totally occluded. And if you lose a fair amount of function of ventricular systole, then that person is perhaps going to be on a transplant list. So I think that is it. Yay, we're done. So I will see you next Thursday. We will talk about vascular pathophysiology, and I'll get into more about coronary artery disease and ischemia and atherosclerosis and what happens when you form clots, etc., etc. So it'll be another fun lecture, and I will see you then. Take care.